I'd like to go back in regard to our discussion about the etiology specific or etiology non-specific therapy, and we are hearing different opinions already. I'm going to try to re-summarize it, but let me hear first further thoughts. So Ahmed, patient of yours, he kind of comes in and you say, patient, you are hepatitis C related, you have hepatitis related HCC. I definitely would like to recommend to use sorafenib, and of course the automated thing that I'm going to do after regorafenib. And the patient look at you and say, oh, but I heard about this drug lenvatinib, and they really insist they want to take lenvatinib. Will you be adamant, no way, I'll give you this? Or how in other words, how solid is your data in regard to hep C related HCC should be with sorafenib?
Yeah, so up front, we really don't have any randomized data to show, and that's what we always love to be able to discuss with our patients. So in general, you just have to know your patient inside out, and by that I mean upper endoscopy, you look at the scan yourself, evaluate the varices. If this patient has got grade 3 varices, the risk of bleeding on lenvatinib is higher than sorafenib. So you really have to weigh the risk-benefit ratio and discuss this upfront with the patient, and a lot of patients love that, to be able to discuss the pros and cons. So we all would love to have very nice randomized data in every risk factor, hep C related HCC versus B, but we all know we're never going to see those studies. It's very hard to conduct and accrue and complete. So until then, I think it's going to have to be up to the clinician and the patient weighing the risk-benefit ratio, the risk of very strong anti-VEGF drug like lenvatinib under blood pressure. Maybe their blood pressure is very hard to control with 4 anti-blood hypertensive medications. Their varices are at severe risk for bleeding. So these factors are going to have to determine what to start with.
Fair enough. And Anthony, to carry on the same question, and I like what you said, but I'd like to dissect it further. And if you recall from your nice data in regard to the nivolumab, which I remember many years ago, even when you presented at ASCO, I also was asked to comment on how much clarity or non-clarity that we have in regard to etiology-based response to checkpoint inhibitors. So, Anthony, I hear that with the checkpoint inhibitors, which remember you nicely presented more than once on the 040, and I remember I was asked to comment on at ASCO when you presented, like, is there any kind of particularity or interest in regard to hepatitis C versus hepatitis B response, or it's the same?
So the initial data we have, again, with both Nivo and Pembro, that responses occurred across all groups independent of etiology. Again, in the cohorts, for example, in Checkmate 040, it had separate expansion cohorts, Hep B, Hep C, non-infected, sorafenib exposed or non-exposed. None of these were really powered to be compared to each other, but numerically you saw objective responses across all the cohorts, and they were within the same range when you look at the confidence intervals. So at this point, this is the data we have. Now, when we start looking at the larger phase 3 studies, like Checkmate 459 in first line, sure, Keynote 240, we're still relying on, again, subgroup analyses. And there is a non-infected group, for example, in Checkmate 459 that's called out. If you look in the subgroup analysis, that maybe that group doesn't benefit as much, but who knows what that means? It's a subgroup analysis. The numbers get much smaller. So we're gonna need in the future, as we now have more available therapies, to really refine how we do clinical trials and dig deeper into the etiology story and maybe marry the etiology and the carcinogenesis mechanism to the therapy a bit better. But my short answer, right now, responses seem to occur across all etiologies similarly.
Fair enough, fair enough. And Catherine, back to you. So now, the Hep B and C, and you mentioned already, and you described it very clearly, they are not friends, they are not brothers, they are not even cousins. Mm-hmm. They are really way separate from each other. How much do we know? Because if you recall, from your part of the field, Snorri Thorgerson, a long time ago from the NCI, described to us that the pathway, how the cancer evolved in regard to Hep B is totally different from how it evolves in regard to Hep C. You know, for example, the RAF-MEK-P-ERK, and this is what Dr. Kassib is really kind of stressing on, the interest in sorafenib for Hep C. How much do you make out of this?
I think it's very interesting about the molecular mechanisms with the different viruses, as well as with, the metabolic-related liver disease, such as NASH. There's also different mechanistic developments in that case as well. We've also been able to molecularly subtype HCC into about 6 different subtypes, depending on which pathway you choose. I'm not sure at this point that we have enough data to say Hep B patients should get X, Hep C patients should get Y. I think that we clearly know that if somebody has virally active disease, they benefit from control of the virus, right?
Fair.
Hep C patients, if you get the virus under control, you treat them, you cure them, their liver generally does better. Hep B patients, you suppress the virus during their cancer treatment. It's clear that they respond better to the cancer treatment and their liver function stays stable. So that's about as much as I would make of the underlying etiology at this point, other than saying it's really interesting and I think there is something there, we just need more data.
I like it. And I'll go back to Peter. So let's take an example, Kappazantium. And, admittedly, I know the data. And if I recall, at least the best I can say, it's not like there was any amazing, beyond impressive difference between Hep B versus Hep C. Would you say that Kappazantium should be used more preferentially for one group versus the other, or it's really like available for all?
I would not. I think it remains the data on etiology of liver disease dictating differentially one agent or the other are certainly not there. Perhaps, as Dr. Kassa pointed out, the best longitudinal evidence of some sort of a signal for one agent being more effective in HCV patients versus others is that for sorafenib. Interestingly, not only from the positive studies like SHARP in Asia Pacific, but even more so in failed trials, including those for brivinib, erlotinib, et cetera. So I think if one makes a rationale to maybe in first line choose sorafenib in those patients, it might not be entirely based on just opinion. It might actually have some evidence to support it. But beyond that, I do not see that there is anything beyond maybe nuances that would guide us in terms of our treatment decision.
I like the fact that we were able to put everybody on the same page. We kind of started a little bit with different views in regard to the etiology and the treatment choices, but seems we settled in to really appreciate and all of us recognize the limitation of any data that really suggests that to us in one way or the other. And as such, as Dr. Ghulam is saying, that after all, a patient who needs cabozantinib, for example, irrespective of the etiology, they need the cabozantinib. And interestingly, to go back to the point that actually also Catherine was bringing up, despite that we had those kind of data published almost more than 20 years ago that tell us that the etiology will drive a certain pathways in regard to the development of the disease. Data that was published recently is suggesting differently. If anything, from our program at Sloan Kettering, we published that in CCR, and we have shown actually that, I'll take a little bit of a Manhattan subway map, like if Hep B is like right on the west side subway line, number like 1, 2, 3, the red line, and Hep C is on the green line on the east side, number 4, 5, 6, and as if they are totally separate and they evolve with the HCC along those two lines, it's not really the case. As we all know, there's what's called the S line or the shuttle line between the west side and the east side at 4-second Street, and it's really where Hep C and Hep B and Hep C can mix up together. It's really only a suggestion that after all, patients who are really have a certain etiology of disease, the idea that they are only on one specific pathway of development of their disease might not necessarily be true, and others under certain stressors might actually evolve to another line of the evolution of the genetic makeup of the tumor. And this is very important to go back where we started. Biopsy is critical, as we heard, and funny enough, we might not even leave you with only biopsy is critical, but we might leave you in the future, we might say to you, biopsy is critical more than one occasion, i.e. at every progression, maybe we need a biopsy. Well, time will tell, of course.